Okay, well, we'll go ahead and get started. I think you'll enjoy this afternoon session very much. We're going to kick it off with a short talk by Colin Barker, who's one of our interventional cardiologists over here. Colin trained in New York at NYU. That's where he went to medical school, and then he went to Vanderbilt, where he did his internal medicine. Am I getting this right, Colin? And then you went to New York for cardiology, and then he went to Scripps for interventional, and then he saw the light and he came to Houston, and he's been with us for several years now and is really one of our champion structural heart cardiologists, and we're very sorry to announce that we'll be losing him. April 15th is his last day when he goes back to Vanderbilt as chief of interventional cardiology. It's been a great pleasure to work with Colin over the last several years over here in the TAVR program, and he really leads our structural heart mitral program and has a deep knowledge of really what the evolving state of mitral interventional therapies are. So without further ado, Colin.
Great. Thanks, Mahesh, and Moritz for having me come here. So this will be basically a broad overview and a little bit of a device parade, frankly, but at least give you a sense of what's out there. I'd argue right now there's not really any state-of-the-art for replacement because nothing's established or approved, but we'll at least get a look at some potential future devices. So as far as repair, there's only one approved device, and that's the mitral clip. There's a competitor device, the Pascal from Edwards, which is well into their clinical trial, so soon there'll be more than one option. And there are a lot of different techniques for repair, which we'll go over. Briefly at the end, we'll go over the mitral valve replacement landscape, but as I mentioned, there's really nothing that's panned out yet, and we'll highlight some of the challenges of the initial attempts at percutaneous transmitral valve replacement. So I'm sure you've all seen the mitral clip system, a 24 French transvenous transeptal leaflet apposition device. It's now gone through several iterations where now there's two sizes, and soon there'll be devices that can grasp the leaflets individually. Right now it still has to be a simultaneous grasp. Here's an example of a case actually Dr. Ramchandani and I shared several years ago. A 65-year-old who was found to have a brain tumor, pretty aggressive from MD Anderson, pulmonary hypertension, and needed urgent surgery, but was found to have a significant flail in his P2. And right now, or as of a month ago, degenerative mitral regurgitation was the only indication in high surgical risk patients as far as the approval is concerned. That's now recently changed with the COAPT data and the recent approval for functional MR. But for the most part, we were doing primarily prohibitive surgical risk degenerative MRs. And here's two stills, which is these procedures are done under TE guidance with a lot of 3D TE, which really requires an expert. And this is after the first clip went in, and you can see there's still a significant amount of mitral regurgitation. It might not look that severe, but when you look at the PISA, it's actually at least moderate, if not moderate to severe. So we decided to put a second clip in, and one of the beauties of this procedure is we can put a second clip in and measure the diastolic gradients, and if it goes up to, our cutoff is generally 6 millimeters of mercury. If it goes above 6 millimeters of mercury, we won't deploy the device, we'll take it out. But after two clips, you see now we're back down to an acceptable result of trace to mild mitral regurgitation. But these are the referrals we usually get, and this is a case of a woman with a non-ischemic cardiomyopathy, really optimally medically managed, but still symptomatic from a heart failure standpoint, and has severe functional mitral regurgitation. And so our challenge now is sort of putting all the data together. We have two large randomized trials that show conflicting evidence. This is the MITRA FR data, which was a French study that randomized patients to mitral clip versus mitral clip in medical therapy and showed no difference in death or heart failure hospitalizations out to 1 year. As opposed to the US trial, which is COAPT, which had the same design but about twice as big, and it showed a significant difference with a significant advantage of a mitral clip in addition to guideline-directed medical therapy. with regard to death and heart failure hospitalizations. But when you look a little bit closer, there are some significant differences between the two trials. One is anatomy, two is how the patients were cared for, and three are, frankly, some technical issues and outcomes. So clearly, when you look at the mitral FR patients, they were more a moderate MR group with very bad dilated ventricles. So probably a little bit too far beyond where they would get any benefit from a mitral valve intervention, as opposed to the coapt patients who had less sick, smaller ventricles, and more severe MR. So there's now talk about discordance and concordance between the degree of MR and what the ventricle looks like, and people are coming up with algorithms as far as patient selection. Medical management was very different between the two trials. The mitral FR was sort of whatever their cardiologist was doing, as long as they were on a few things, they were checking boxes. Whereas in coapt, even on the screening calls, the doses of specific medicines were being scrutinized, and we were really being pushed to really push medical therapy and optimize people, and then confirm, despite that, they still were symptomatic with severe MR. So I think a difference in how they were taken care of. And lastly, technically, the people in France, these were all new operators to the mitral clip, whereas in the US, most of the sites had experience already. So the outcomes were different. I mean, leaving the procedure with greater than 3+ MR was twice in the French study as opposed to the US. The complication rates were about twice in the procedures in the France study versus the US. And the durability was much greater in the US, with only 5% of patients having greater than or equal to 3+ MR at 1 year, where that number was 17%. So these are things we're now thinking about when we get these patients, these dilated cardiomyopathies. Is this someone who would benefit, someone who we need to push medical therapy a little bit more, or is this someone who's too far beyond therapy? So here's the Edwards Pascal transcatheter mitral valve repair system. Looks very similar to a mitral clip. There is the idea of this spacer that may help filling in some of the regurgitant jets. One of the advantages, as I mentioned, the clasps allow for independent leaflet capture as opposed to simultaneous capture. And here's an example of a Pascal case. And you can see that they've already grasp the anterior leaflet, and now they can just take their time and go to the posterior leaflet. And this will have, I think, particular advantages when they move this, which they already plan to pretty quickly, to the tricuspid space, where it's quite a challenge to do a tricuspid clip. I mean, we've done a little over 20, but they can be very difficult, long procedures with marginal outcomes at best. So here's the completion of the Pascal, and really a reasonable result as far as minimizing the mitral regurgitation. So the landscape right now, as far as repair and replacements, is really overwhelming. And clearly not all of these devices are going to pan out. And in fact, there's several on these lists that have already gone out of business or fallen off the charts. But there are still a lot out there, and I'll just run through a couple here. And you can sort of break them up into different categories, with edge-to-edge repair, coronary sinus annuloplasty, direct annuloplasty, and then different types of replacement. And now there's even some mitral leaflet technologies that are in very early feasibility studies. So this is the Cardioband that Edwards now owns, that's approved in Europe, had a trial here that's been put on hold, but it's a transseptal annuloplasty system that apparently, having talked to people, we have never done any here. We did it in an animal before the trial got stopped. But in Europe, they say it does get fairly quick with more experience, but it requires putting in 14 of these screws. One of the advantages that this potentially could have is if you had someone who had a prior therapy like a mitral clip and still had significant residual mitral regurgitation, you'd have the option of bringing them back, and rather than putting another clip on and maybe causing prohibitive mitral stenosis, you can use an annuloplasty device to sort of complement the leaflet. Another annuloplasty device by Amend is called the Techno. This is a nitinol ring and anchoring system that's for now delivered transapically. There are transseptal prototypes, and it allows for real-time positioning and alignment And here's an example of a case. So this is being done transseptally, and it has these 6 locking mechanisms to attach to the atrial side of the annulus. Here's the harpoon device, which again is done transapically to replace cords. We haven't done any of these here, but in talking to people who have put them in, the short-term results have been good, but the durability has come into question. And you as surgeons might understand this a little bit better than I do, but one of the hypotheses is that they're actually puncturing through the leaflet and the body of the leaflet and using that to tether down these cords rather than the tips of the leaflet, and they've just had issues with recurrence of mitral regurgitation. But again, it continues to be in clinical trial. And here's an example, obviously, of we would only show a successful case, but this is immediately after the procedure. It looks good. One of the sort of not quite ready for prime time devices is the ARDOS system. It uses the cardiac veins for part of the equipment and executing the procedure. But unlike the other devices out there that sort of put an annuloplasty, this is one of these devices that puts a cord across the orifice of the mitral valve in order to bring together the anterior-posterior mitral annulus. So here's a little cartoon showing how it works. It's done from a transvenous internal jugular transfemoral simultaneous approach using magnet technology to puncture posteriorly a wire, and then use that wire to guide up a cord that has an anchor that stays in the cardiac vein. And then on the transseptal side, there's an occluder placed, and the two are used to essentially bring together the annulus. This is sort of fantasy right now, but it is a company that's doing their first-in-man trials outside of the United States. And here's one of their cases from Australia. You see the baseline echocardiogram on the left, immediately post-procedure, and you can appreciate the cord there. And then at 1 year follow-up, they still had a good result with this patient. Something that's more ready for prime time, which you'll see the US clinical trial starting before the end of this year as Boston Scientific acquired Millipede. And this is a complete semi-rigid annular ring that's done transfemoral, transseptal. It's fully repositionable and retrievable and preserves all the native anatomy. So essentially, it's put through a sheath, and there are these anchors, again, little screws that go into the tissue, and then there are these actuators that allow you to change the size of the annulus. And here, again, one thing these guys are all really good at is making these animations. But here's an animation of how this works. One unique thing is that probe that just came down. So the screws are put in under ICE guidance. So that's an intracardiac echocardiogram that goes through the delivery sheath, and it focuses in on each of these screws. So ICE is used as opposed to TEE as imaging guidance for actually putting in the screws. And then the ICE is removed, and then when it comes to releasing the valve and adjusting the actuators for your sizing, that is all done by TEE. So that's something exciting, and I think we'll be doing actually pretty soon. So switching gears to transcatheter mitral valve replacement, the design goals include, obviously, in some of the mitral repair systems, leaving a little bit of mitral regurgitation has been tolerable. With the replacement, that's going to be less tolerable. One of the issues also with replacement that's been a challenge is obstruction of the LVOT, which I'm sure we've all seen. Paravalvular leak has been somewhat overcome. Because of the heterogeneity in mitral disease, there's going to have to be a wide range of devices and sizes. They're going to need to be durable and easy to implant, and ultimately, as of right now, most devices are transapical, but ultimately transseptal would be more ideal. So the issues of the current annular-based transcatheter mitral valve replacement technologies include device embolization, LVOT obstruction, device fracture and even impaired LV function due to chordae tendinate damage as well as transapical punctures. Here's one of our early cases in a TMVR. We're part of the Intrepid Apollo program. And this was an older gentleman who was sort of stuck on milrinone and in the hospital with decompensated heart failure, had prior two cabs, has severe functional MR. And this is what the device looks like. It has a conformable outer stent that engages the annulus and provides fixation and sealing, while isolating the inner stent, which houses the 27 millimeter tricuspid bovine valve. And then the flexible brim really doesn't have any structural function, but it facilitates imaging, as you'll see here. So here's our case, and so you can see it's done transapically with TEE guidance, and you can see we're using those brims to actually guide the position in the X-plane, which is showing us medial lateral and anterior posterior images. For deployment, we do rapidly pace, and a little bit of this is also done under fluoro, but most of this whole procedure is done with TEE guidance. You can't retrieve it. It's sort of, you get one shot, and you got to hope that it works. But immediately post, we have a good functioning, well-seated valve without any left ventricular outflow tract obstruction. And when you compare before to after, you can appreciate that really there's no effective orifice area anymore. You have a normal functioning bioprosthetic valve. This data has been presented in the initial 50-patient feasibility study, which showed a 1-year survival of 76%. This now is in randomized trials to surgery and has been incredibly slow to enroll. There's over 60 sites, and we're one of them, and it's a 1.5 years into it, and they've entered 9 patients into the trial, and it's supposed to be a several hundred patient trial. This is a sample of the landscape of the potential TMVR devices out there. Again, some of these, like Cardiac Q, have already kind of come and gone. There have been iterations on several of these. And there's one I'll show you at the end that's not up here that's interesting, but it's going to have its own issues as well. So the other active trial in the US is Abbott's Tendyne transcatheter mitral valve, again, a tri-leaflet porcine valve, made up of self-expanding nitinol, as is the 12 valve. They do have more size options. It is and will always be transapical. As part of the device includes a little apical pad that can be used as a tether. And here's what one looks like on 3D CT after it's been implanted. And you can appreciate the valve is well seated, and it has that tether and that little foot at the apex, which we theoretically is actually having other roles rather than just a safety tether. But seems to early on, again, we haven't done any of these, but have seen and heard from friends and colleagues doing this that they're very happy with their results. They presented their initial 30 patients and showed a all-cause mortality out to a year of 0.83. The device that's now been done several times in Europe and coming to the US is the HiLife. And this is a 2-step procedure, and it's been termed the valve and ring because first part of the procedure is placing a ring, and the second part is placing the valve. Now the ring is placed transfemorally retrograde across the aortic, and then the valve is actually placed transapically. Theoretically, in the future, everyone wants a transeptal device, but right now it's done entirely transapically. And here's a example of one of their early cases done in Europe, where you can see this sort of valve in a ring working very well without any residual mitral regurgitation. One concept that I like, and we're part of this, is in the first in man studies, is 4C. And this is very unique. This sits entirely in the left atrium. There's nothing in the annulus or in the left ventricle. So it's completely supra-annular, so you don't disrupt anything about the native mitral valve. It's again, as all these are, self-expanding, so it can go through, it right now goes through a 30 French sheath, and right now it's only done again, transapically, but they do have already transseptal devices that'll be coming out soon. And again, really cool animations. So they've done 2 of these so far in Canada, and one did well and one didn't. And it's always hard to say, you know, if that's really the device's fault or the patient's fault. Right now, it's never the doctor's fault. But you know, these are going to be very sick people, you know, who don't have other options, frankly, who go to first in man. But what you see is it's this big nitinol cage that fills in the left atrium, and you can see nothing is disrupting the native mitral valve. And it's sort of conceptually difficult, but you don't do any, the patient still has severe mitral regurgitation, but the left atrium and pulmonary veins aren't seeing that mitral regurgitation because it's being stopped at that supra-annular valve. So here's an initial study showing that idea. And if you can appreciate, there is still mitral regurgitation below the valve there, but it's not getting up into the left atrium. So, you know, in closing, I think the challenge with these devices I highlighted with LVOT obstruction, embolization, et cetera, and maybe these supra-annular devices are going to be a potential alternative. For the most part right now, we're dealing with very sick patients who don't have good surgical options, which can make, you know, some of these survival curves a little bit misleading. All these devices go in incredibly large catheters and therefore require transapical approaches. So until that's optimized and this can be done transfemorally, transseptally, I think there are going to be continued limitations with this really becoming state-of-the-art or prime time. Long-term durability, of course, is always an issue, but something that's particularly challenging in the transcatheter mitral valve replacements is anticoagulation. These people all need to be on Coumadin. And they really even want the Coumadin started day of the procedure, and that can be challenging in someone who just got a transapical device. Given the COAP data, most, if not all of these trials are targeting functional mitral regurgitation, and they're not randomized. They're randomized to medical therapy. But the argument now is, well, we have something better than medical therapy. The trial design is probably going to have to change a little bit and include the mitral clip in the control arm. And when you see the data from COAP, the bar is set so high, it's going to be challenging for a transcatheter mitral valve replacement to do, I think, much better than a mitral clip. And lastly, clearly, there's just too much out there. One or two techniques, devices, whatever, need to sort of take over. You know, Apollo we like and we're part of it, but again, just very challenging to find these patients, but we'll continue to do so. They'll probably have to adjust their protocol to include mitral clip in the control arm. And with that, I'll thank you.